Welcome to Medico Mallu. Today we are going to discuss the topic cerebral palsy from Pediatrics. What is cerebral palsy? It is a static, non-progressive encephalopathy which is due to insult to the developing brain. From the term non-progressive means the disease doesn't worsen. It is non-deteriorating and the acquired skills are not lost and the lesion is permanent. From all these terms, we understand it excludes cerebral tumors and degenerative brain disease, where these are just opposite to the cerebral palsy, where the disease worsens and there is progressive deterioration of the disease. The most common presentation in the cerebral palsy is developmental delay, the most common cause being the perinatal asphyxia. And cerebral palsy is the most common chronic motor disability in the childhood. Etiology. The Santosh Kumar textbook has given a mnemonic JAP-B, J for jaundice, A for asphyxia, and Pre for prematurity, prenatal causes, perinatal causes, and B for brain anomalies. Prenatal causes like intrauterine infections, intrauterine cerebrovascular attack, perinatal causes like hypoglycemia, traumatic delivery, etc. Brain anomalies can be of two, congenital and acquired. Congenital like neuronal migration disorders and acquired like encephalitis and meningitis. These are the common etiology where the prematurity is the most common cause. Assume this is the time of the brain development. From there till the birth, these are the prenatal insults damaging the developing brain. From the birth to the present time, there can be the postnatal insults too. Let's see which are the other causes. Prenatal causes like intrauterine infections, cerebrovascular attack, intrauterine growth restriction IUGR, low birth weight, neural tube defects, genetic causes, cerebral malformations, multiple gestations, physical trauma to the mother can cause cerebral palsy. In the perinatal time, asphyxia is the most common cause. It can be due to prolonged labor, abnormal presentation of the baby, instrumental delivery, and even cesarean section. Let's see which are the postnatal causes. Neonatal hyperbilirubinemia, sepsis, intracranial hemorrhage due to any head injury, metabolic causes like hypoglycemia, convulsions, and neonatal meningitis. Let's see which are the presentation of the cerebral palsy. Wide variety of issues are noted. The clinical features are based on the site of insult, and anyhow, developmental delay is the most common presentation. Let's see how. If there is an insult to the developing motor cortex, then it causes gross motor defects in the baby, like baby cannot move his lower limbs or the difficulty in moving his hands. If there is insult to the developing visual cortex in the occipital lobe, then it results in visual defects. Whereas if the insult is in the developing cerebellum, then it results in fine motor issues and coordination defects in the baby. Next, we have to see the classification of cerebral palsy. Mainly, there are four types. The first one is spastic cerebral palsy. Here, the lesion is in the cerebral cortex and it is an UMN lesion. According to the UMN lesion, there is exaggerated reflexes and hypertonia, and that results in this spasticity. This hypertonia results in scissoring gait and toe walking. And what is this scissoring gait? The lower limb of the child or the baby are crossed to each other, and toe walking means the child walks in his toes due to contracture of the calf muscles. Which are the causes? It's mainly due to the perinatal asphyxia, prematurity, neonatal sepsis, and ischemia. There are three subtypes of spastic cerebral palsy. First one is the diplegic cerebral palsy, where weakness are seen in both upper limbs and the lower limbs, but the weakness in the lower limb is greater than that of the upper limb. It's due to the insult in the periventricular area representing the limb. Second one is the quadriplegic cerebral palsy, which is the most common type, where all the four limbs are affected equally. And finally, the hemiplegic cerebral palsy, which means half of the body of the child are affected. The child shows early handedness. This is due to a stroke in utero, that is, a cerebrovascular attack while the baby is in the uterus, and most commonly in the region of middle cerebral artery supplying the internal capsule. And this is all about the spastic cerebral palsy. The second one is the dyskinetic cerebral palsy, or athetoid or extrapyramidal cerebral palsy. From the name itself, the lesion is in the extrapyramidal system, and that is in the basal ganglia. The basal ganglia lesion causes involuntary movements like dystonia and chorea. Dystonia is abnormal muscle tone disorder causing abnormal posturing. In the chorea, there are jerky, dancing, involuntary movements, and this is due to asphyxia or kernicterus, which is deposition of the bilirubin in the basal ganglia. The third subtype is the cerebellar or ataxic cerebral palsy. From the name itself, the lesion is in the cerebellum, and it results in the loss of coordination of the movements, defective fine motor movements, and the child starts showing cerebellar signs. And it is due to head injury, prematurity, asphyxia, etc. And finally, the mixed cerebral palsy, where the ataxic diplegia is seen, which means the child shows combination of cerebellar lesions as well as the spastic cerebral palsy lesions. Secondly, the dystonia and or chorioathetosis associated with various spastic cerebral palsy features. And these are the four subtypes of the cerebral palsy. Which are the other comorbidities of the cerebral palsy? The child will show mental retardation, recurrent seizures, hearing and speech difficulties, ocular or vision defects, and behavioral disorders. Let's see which are the high risk factors. In the mothers, poverty, poor medication or poor access to the health care is a major risk factor. Previous history of IUGR or low birth weight, and the maternal age during conception. If it is a very young age, less than 16 years, or even in older age, more than 35 years, they are high risk factors. Maternal diseases like congenital heart disease, diabetes mellitus, hypertension, sexually transmitted diseases, and infections like torch. If there is infections like torch during the antenatal period, then the mother gives a history of fever with rash during the antenatal time. And history of drug intake like anti-epileptic drugs like phenytoin or valproate are higher risk for developing the cerebral palsy in the newborn. And which are the higher risk factors in the infants? Prematurity and lesser the gestational age below the 37 weeks, and more gestational age more than 42 weeks are risk factors. Apgar score less than 4, LSCS lower segment cesarean section, and instrumental delivery small for gestational age or large for gestational age babies, and even fetal distress are risk factors for developing the cerebral palsy. And let's see the clinical features of cerebral palsy. Developmental delay is the first and foremost presentation, where there are delayed milestones, and it can be associated with delay in appearance of new reflexes like parachute reflex, Landau reflexes, etc. And this is due to insult to the developing brain, and that can cause microcephaly too. Next, there can be persistence of neonatal or primitive reflexes like Morose reflex or ATNR, asymmetrical tonic neck reflexes. And there can be reduced or increased tone, that is hypo or hypertonia, and that can cause poor neck control, toe walking, scissoring gait, and even commando crawl. In commando crawl, the child crawls like commandos in the armies due to weakness in the lower limbs. And there is another term, W sitting, where the child sits like a W pattern, and this is due to the child's inability to sit properly as a normal child. And this hyper or hypotonia can cause hyperreflexia, contractures, and abnormal posturing and gaits, etc. Next feature is the fisting with cortical thumb persisting for more than 2 months. And this image shows the fisting with cortical thumb where thumb is inside the fist. And this is a typical feature. Next, early hand preference within 1 year that we have seen, and it is in the hemiplegia or in case of one upper limb weakness too. And we can see a delayed social smile in the baby. Normally it is seen at 2 months. The child will be having a high pitched cry, and there may be reduced spontaneous activity too. And next we have to ask the mothers which are the most common problems. They are usually swallowing and feeding difficulties and nasal regurgitations, which are the most common cranial nerve problems. And these are due to 9th and 10th cranial nerve lesions. And difficulty in changing diapers due to scissoring gait or hypertonia in the lower limbs. There can be hearing and vision defects, kyphoscoliosis, and recurrent urinary tract infections and lower respiratory tract infections like pneumonia. And the child will be having constipation and malnutrition like features. Which are the other problems? Difficulty in carrying the child at the lap due to hyper or even hypotonia. Asymmetrical limb movements, arching of the body due to hypertonia, and there can be delayed 4S's. These are social smile, sitting, standing, and speech. While a CP, cerebral palsy child is presented in front of you, then you have to take a proper antenatal history. In the antenatal history, we have to ask points like whether there is any reduced fetal movement. If so, it is due to hypotonia. Increased fetal movement can be due to fetal seizures. Ask whether there was any features of oligohydramnios. It can be due to renal defects or even IUGR. Polyhydramnios can cause if there is any oropharyngeal or esophageal abnormalities. Ask about any twinning history, IUGR or congenital anomalies, or even premature rupture of membrane, fever, UTI, abdominal tenderness, or any foul smelling liquor during the antenatal history, which rules out the sepsis. We have to do a proper head to foot examination in the cerebral palsy child. In the head, we can see microcephaly, open anterior fontanelle, abnormal head shape, and even loss of hair. In the face, you can expect some dysmorphism. In the eyes, there can be squint, nystagmus, drooping of the lids, cataract, a roving eye movement seen in blindness. In ears, it can be lozate ears or there can be abnormal pinna. In the mouth, you can expect deviation of angle and drooling of saliva, which are features of facial palsy. In the mouth, you have to examine the dentition and check whether there is any pooling of secretions. In the chest, rule out rachitic changes, deformities like pigeon's chest, etc. In the abdomen, check whether there is any organomegaly and check out the hernial orifices. In the genitalia, you can expect some anomalies like genitourinary fistula. In the limbs, check for any deformities, scissoring gait, tones, and the contractures. In the hip, you can expect subluxation and contractures. In the skin, you have to search for neurocutaneous markers like café au lait spots, tubers, nodules, ash leaf patches and shagreen patches, which are features of tuberous sclerosis, and even look for neurofibromas. We have to examine the child with 180-degree flip. What is this 180-degree flip? The child initially is in the supine posture and we are pulling the child to sit. In the sitting posture, we are examining the child, and next we are holding the child in the axilla like this. At last, we are suspending the child ventrally and keeping the child in the prone position. And thus, this child completes a 180-degree flip from the supine to the prone position, and we are examining the child at each and every steps. In the first step, supine position, examine the child's posture, whether there is any abnormal ATNR reflex, asymmetrical tonic neck reflex. Check out any involuntary movements, etc. Secondly, pull the child to sit and look for any head lag. Thirdly, in the sitting posture, make the child sit. Check the head and the trunk control. Look out whether the back is straight or rounded. Hold the child in the axilla and hang the baby. If you feel the child or the baby is sleeping, then it is mostly due to hypotonia. Look out the scissoring. And here the child's lower limbs are close to each other and look like scissors. Check for the increased extensor tone, and which is due to hypertonia. And finally, the child in the ventral suspension, that is in the prone position. Check whether the child is raising his head. If so, the child has attained the neck control. Check whether the back is arching. This is to look for the extensor tone. And from these, we are determining the developmental age of the child and calculating the developmental delay. Which are the differential diagnoses of cerebral palsy? We have to rule out neurodegenerative diseases, which presents as initially the child or baby will be normal, and on later there is regression of the skills and progressive worsening of the disease. Whereas in cerebral palsy, there is no progression of the disease and there is neither loss of acquired skills too. Secondly, we have to rule out myopathies, which will be having progressive weakness. Thirdly, we have to rule out any spinal cord lesions. Finally, we have to look out the management of the cerebral palsy. It is a multidisciplinary approach, which includes many things like decreasing the contractures, physiotherapy, improve the skills of the child, improve the nutrition, treatment for epilepsy and other comorbidities, and correcting the vision and hearing, and at last make the child independent. You have to think about the schooling of the child. You have to admit the child in a normal school with special teachers and in the class corresponding to the IQ of the child. And this is the multidisciplinary approach. How you manage the contractures? We can give baclofen and diazepam or even local injection of botulinum toxin, and at last surgeries can be performed like tendon release or tendon transfer surgeries for the treatment of contractures. And at last, it is better to prevent the cerebral palsy. If we are giving good care, we can avoid all these issues. Good obstetric care, prevention of intrauterine infections, prevention of low birth weight or preterm labor, prevention of birth asphyxia, management of chorioamnionitis, iodine and iron supplementation during the pregnancy itself, and steroids to the mother in the right time. All these can prevent the cerebral palsy, and it is always better to go for prevention than for cure. And this is the end of our topic. Please note, to be a good pediatrician, you need 4 eyes, 4 ears, and 2 brains, and a lot more patience too. This is your Medicom Melbu. Thank you for watching this video. Please like, share and subscribe.